These are the objectives for the both topics. And we're going to start with foreign body aspiration. Foreign body aspiration means that there is a foreign body in your airways. For the epidemiology, it's mostly seen in children aged less than 3 years, and we're going to shortly see why. Young children usually aspirate food, and the most common food is nuts. And older children usually aspirate rubber balloons. We see some cases of in adults who have foreign body aspiration, and mostly they are elderly or patients with psychiatric issues. For the etiology, usually children discover things using their mouth. That's why most of the cases of foreign body aspiration is in the children. And they usually don't sit still while eating. They sometimes laugh, speak, or even run, which increases the risk of having aspiration. The obstruction could be complete obstruction, and in that case, we're going to have a collapse in the distal airway, in the distal area of the obstruction. Why is that? Imagine if you're having a airway and you completely obstruct it. What do you have in the distal area? We have entrapped air, right? This entrapped air will get absorbed by the blood vessels, leaving the area to be empty, and this area will collapse or be atelectic. We can also, the obstruction could be partial obstruction. In that case, the foreign body might form a one-way valve, allowing air to enter while inspirating and inhibiting air to exit while expirating, causing a hyperinflated lung. And you can see it in X-ray, and sometimes you see a mid-sinus shift in the X-ray. The obstruction also could be in the upper airway, meaning from the larynx and above, or in the lower airway. And the most common location is right main bronchus. Why is that? Because the right main bronchus is more vertically oriented in comparison to the left main bronchus. So foreign bodies usually tend to lodge there. For the clinical features, it depends on the degree of obstruction. For example, if the patient presents with complete obstruction, they can be unresponsive. They will not be able to speak, cry, or cough. You will have paradoxical movement of the chest and abdomen, which means that in inspiration, the chest will move in and the abdomen will move out. And in expiration, it will be the opposite. We can have absence of breathing sound, could be unilateral or bilateral, depending on where the obstruction is. And the patient can present with cyanosis as well. For partial obstruction, patient can have choking and coughing, can have hoarseness, which can tell us that the foreign body is in the larynx. Can have signs of respiratory distress like tachypnea, use of accessory muscles, nasal flaring. Can also present with cyanosis and altered mental stasis. We can hear stridors and wheezing, and when you hear it, it can tell you where is the obstruction is. Like for example, if you hear them on inspiration, they can tell you that the obstruction is in the upper airway. If you hear it on expiration, they can tell you that the obstruction is in the lower airway. Diminished breathing sound on auscultation, and hyperresonance on percussion on the affected site can indicate hyperinflated lung. How do we diagnose and manage foreign body aspiration? The scenario will mostly be that the parents give their child food and suddenly the child developed respiratory symptoms. Or for example, the child was left alone and suddenly they develop respiratory symptoms. And what do you need to do? First, you need to look for signs of complete airway obstruction, as we mentioned before, and it's written here again. If the patient presents with them, or any of them, that means that the patient is having a complete airway obstruction, which needs a rapid action. In that case, you need to look for if the patient is responsive or not. If the patient was not responsive, you can start CPR and doing chest compression. You need to do head tilting and chin tilting to make sure the airway is open, and you can start doing the chest compression and for 2 minutes and look for the foreign body. If you can see it, you can put your fingers and remove it. If you can't see it, don't put your fingers. And you can repeat that. If it failed, we can do laryngoscopy with forceps. We try to remove the foreign body with the forceps. If it failed, we sometimes do endotracheal tube insertion, and we push the foreign body distally to allow us to ventilate the lung. If this also failed, we can do tracheothyroidotomy, where we make an incision below the obstruction and insert the tube to allow for ventilating. If the patient was responsive, we can do back blows and it depends on the patient age. If it was infant, we can put them in our forearm and support their head with by holding their jaw and gently tapping on their back or doing back blows to increase the intrathoracic pressure and allow the foreign body to dislodge. If the patient was an older child, we can make him do this maneuver and put one of our hands in the chest to support it, and with the other hand we can do back blows to increase the intrathoracic pressure and allow the foreign body to dislodge. If this failed, we can look at the age of the patient. If they were infants, we can do chest thrust, and if they were adults or children age more than 1 year, we can do abdominal thrust. If they failed or the patient start to lose consciousness, we can do the chest compression and the laryngoscopy and so on. If the patient didn't present with any signs of complete obstruction, we can assume that the patient is having partial airway obstruction. And in that case, we need to know if it was in the upper or lower airway. And how do you know it? By the signs. If the patient presents with stridor, sternal retraction, use of accessory muscles, and difficulty swallowing or drooling, this may indicate that the patient is having obstruction in the upper airway. And if the patient is stable, we can do X-ray, neck X-ray. If we saw the foreign body, we can encourage the patient to cough. If it failed, we can do laryngoscopy or nasal endoscopy to remove the foreign body. If we couldn't see anything in the neck X-ray, we can directly go for laryngoscopy or nasal endoscopy to visualize and remove the foreign body. Of course, if the patient was unstable, we don't do the X-ray, we directly go and do laryngoscopy. In signs of lower airway obstructions, like the patient presents with cough, absence of breathing sound in the affected lung, or wheezing, we can do chest X-ray and detect the foreign body. If we saw it, we encourage the patient to cough. If it failed, we do bronchoscopy to remove the foreign body. If the chest X-ray didn't show us much, we can go for CT scan or directly go for bronchoscopy to visualize and remove the foreign body. Again, if the patient was unstable, we directly go and do bronchoscopy without the imaging. Complications, atelectasis, as we discussed. Patient can present with post-obstructive pneumonia and lung abscess, especially if the foreign body was left there for a long period. Incomplete obstruction, sometimes patient can suffocate and die and can have brain damage due to hypoxia. This is an interesting case report that I found. It talks about a 7-year-old male who presents with foreign body aspiration. And he presents with the signs of partial airway obstruction in the lower airway. They tried to do bronchoscopy to remove it, but they failed due to multiple reasons. So they had to do an open surgery to remove the foreign body, and it was successful, and he was discharged and fine, alhamdulillah. Okay, for the foreign body ingestion, it means that there's a foreign body or non-food material in our GI system. For the epidemiology, the incidence peaks at 6 months or to 3 years of age, and the majority of cases is in pediatrics, and mostly the foreign body passes continuously without any medical intervention. Sometimes we see cases of foreign body ingestion in adults, especially in prisons when they try to smuggle things using their mouth, or in patients with psychiatric issues. Foreign body may lodge in any part of the GI system, like for example, the esophagus, stomach, or intestine, and can cause obstruction if it was big, traumatize if it was sharp, or burn if it contains chemicals. For the etiology, children, like the foreign body aspiration, children discover things using their mouth, and they might accidentally ingest a non-food material. The most commonly ingested foreign body is coins, and this based on studies in the US and in Saudi Arabia. But in other countries, the most common ingested foreign body was fish bone. Other common examples could be small batteries or button batteries, toy parts, or sharp objects. For the clinical features, it depends where the foreign body is lodged. Most commonly, it lodged in the esophagus, and if it passes the esophagus, mostly it will pass continuously without any intervention. What are the clinical features if the foreign body is in the esophagus? Difficulty swallowing or dysphagia, excessive salivation, refusal to eat, chest pain or foreign body sensation, and cough and hematemesis. If it was in the stomach, usually the patient will be asymptomatic but can present with abdominal pain and nausea and vomiting. If it was in intestine, It will be usually asymptomatic, like the stomach, and could present with abdominal pain or bloody stool. How do we diagnose? We need to take a detailed history and physical examination. In the history, we can have an idea what the foreign body is and how many of the foreign body the patient ingested. And in the physical examination, we can focus on signs of esophageal perforation, like fever, tachycardia, tachypnea, crepitus in the neck or the chest region. We can also look for signs of bowel obstruction, like abdominal distension, hyperactive bowel sound in early stages, and hypoactive bowel sound in late stages. We can do imaging, like X-ray for the neck, chest, and abdomen. And we can detect radio-opaque foreign bodies like coins or batteries. How do you differentiate coins from batteries in in X-ray? It's important because batteries need quick actions because they can cause severe symptoms within 1 hour. Coins usually circular and radio opaque on X-ray. While batteries, if you visualize them in the anterior view, usually they are 2 circles, and if you visualize them in the lateral view, usually they are 2 layers. For radiolucent object, we can see their edges using X-ray, and we can see a free air, which can indicate perforation. For the CT, it's indicated if the foreign body possesses risk for complications, like for example, it was sharp object or large foreign body, like to make sure of it, and if the X-ray was inconclusive. MRI could be used to detect radiolucent foreign body, but it has one condition, and that is we need to know what is the foreign body, because if it was a metallic object, MRI is contraindicated. Sometimes we do endoscopy without any further imaging, both for diagnosis and management. How can we manage patients with foreign body? As we said, foreign body ingestion usually passes spontaneously without any intervention. And how do you know that this patient has high probability of passing it spontaneously? Usually the patient will present asymptomatic and the foreign body is in the esophagus for less than 24 hours or in the stomach or intestine. This scenario, the patient have high probability to pass the foreign body spontaneously. Sometimes we need to do endoscopy in certain cases, like for example, if the patient, if the foreign body is causing severe symptoms like respiratory distress or signs of perforation, we need to quickly act. If the foreign body is bottom battery in the esophagus, like we said, bottom battery can cause severe symptoms within 1 hour, so we need to act fast. If the foreign body is multiple magnets or magnet and metallic object, because they can pull each other and cause perforation. If the foreign body is sharp object in the esophagus, because esophagus is a narrow area and the sharp object can damage, causing ulceration. In these scenarios, we need to do an emergency endoscopy, where we need to act within 2 hours or less, because they can cause severe complications if left for a long period. Other scenarios we can use the endoscopy are foreign body with any symptoms, foreign body in the esophagus for more than 24 hours, so the monitoring failed. Foreign body is a bottom battery in the stomach or intestine without any symptoms. Foreign body is a magnet or sharp object in the stomach or intestine without any symptoms. And in these cases, we need to do an urgent endoscopy, where we need to act within 24 hours or less. Sometimes we need to do surgeries, especially if the endoscopy failed or the foreign body is in the lower GI system and can cause signs of and the patient present with signs of bowel obstruction or perforation. Complications of foreign body ingestion are rare, but they could be esophageal or stomach perforation, mucosal erosions, pressure necrosis, failure to thrive secondary to decreased oral intake. And by that, we finished the presentation. If you have any question, because we have 2 questions to ask. If you don't have any question, we're gonna move to the questions. This is the first question. If anyone can read.
I can read.
Yes, go ahead.
Okay, so a 2-year-old girl is brought to the emergency department by her mom because of cough and shortness of breath for the last 2 hours. Symptoms started shortly after the patient was left alone while eating a watermelon. Physical examination showed diminished unilateral breathing sounds and intercostal retractions. Flexible bronchoscopy was done. What is the most likely location for the foreign body? A. Trachea, B. Left main bronchus, C. Subglottis, and D. The right main bronchus. It's going to be D. The right main bronchus.
That's correct. As we said, the right main bronchus is more vertically oriented, and foreign bodies usually stuck there. The second question, anyone don't mind to read?
Okay, I'll read. So we have a 2-year-old boy brought with his mother by his mother to the emergency department due to history of coughing for at least 30 minutes. The mother said that her son was playing with his new toy before symptoms started. You did an X-ray and found the foreign body in the esophagus. Found it in the image. And just a minute. So, okay, what's your next step in management? A. Reassure and observe. B. Admit to the OR. C. Emergency endoscopy, and D. Repeat the X-ray. So since we have the coin ingestion, we will do an emergency endoscopy.
But this is actually a bottom battery, because in the anterior view you can see two circles. And
yes.
Yes, that's why but your answer is correct. We need to do an emergency endoscopy.
But Osama, why do you think this is an esophagus, regardless if it's written there? Like, why do you think it's an esophagus, not the trachea? There are like 3 signs already in the imaging.
So first of all, it's when we do the lateral position, it's anterior to the like trachea, and it's
You mean posterior?
horizontally placed.
So it's posterior, you mean, to the trachea, right?
Orientation. Yes.
Yeah, so the trachea is always in front, and if you see the lateral position, you can see the air column going anterior to the object. Other thing is, you will see that the orientation of the object, or the long part of it, is going horizontally. In the trachea, if there is anything to be lodged in the trachea, it needs first to pass through the vocal cord, which is longitudinal. I mean, its axis is from front to back, so it needs to be inserted like through that narrow part. And then, even once it's in the trachea, if there is any part that will be stretching in the trachea, it will be the posterior part. So you will never see the foreign body that big and laying horizontally like that. Now, I mean, side to side. You will see it always like the lateral view in the front view, okay? Because it needs to lodge during or stretch the posterior part that has no cartilage in it. That's the second thing. Even if it was like not mentioned in the question. And then definitely, since it has the double lumen look in the X-ray, that's a battery that you need to do an emergency endoscopy for it.
يعطيك العافية.
And by that, we finish the presentation. Thank you all for listening. If you have any question, and these are the references.
Thank you, Abdullah. Excellent talk. Anyone has any question?
No, doctor, thank you so much.
No questions, doctor. يعطيك العافية عبد.
Thank you.
Thank you.